Okay, so good afternoon and happy Vasant Panchami, everyone. So, welcome to the second session of the Icon Amrita E-Gurukul webinar series. Today's topic of discussion is drugs in gastrointestinal malignancies. These webinar series have been designed keeping in mind the exam going DRNB and the DM and the DM on medical oncology students so who are currently preparing for their final examinations. So it will be my pleasure to introduce Dr. Safalta Bagman Madam, who is a senior consultant medical oncologist at the Amrita Institute of Medical Sciences, Faridabad. Now, Madam is an avid researcher and she has numerous publications, and also she has contributed immensely to the academics by serving as a faculty in the various national and the international conferences. She has also served as a faculty at the Institute of Liver and Biliary Sciences, New Delhi, GI malignancies being one of her areas of expertise. So, without wasting much time, I will hand over to Madam to and invite her to introduce our moderator. So, over to you, ma'am.
Thank you, Barnini, for kind introduction. I have not done so much. and welcome you all the students. And we, as a faculty from Amrita Hospital, as a team, Dr. Pravas, Dr. Prashant, Moshmi, Dr. Vidit, we have been doing multiple series of educating other students, and especially the brainchild behind this whole series is Dr. Karan Sood, who is himself with exam going, but he also wants to educate his fellow students who are exam going. Now I would like to introduce Dr. Lingaraja. So he is a person who has been in initial stages only. He decided that uh, he wants to pursue uh, Viraj Lavingia. So he wants to pursue GI malignancies in very initial stage of his practice. And in a short duration of time, he has become a stalwart of GI malignancies. With his moderation, we will be starting this series of the second class of drugs in GI malignancies. Over to you, Dr. Viraj.
Thank you, Dr. Safalda, and thank you, organizers, for having me here. And very good afternoon to everyone. I remember I was a student not long ago, and I used to remember the classes of drugs like Texans and Platinums or anti-angiogenic as their classes. And, we used to mug up the properties, the benefits, and side effects. And honestly, it was quite boring. It used to be a chore just for the exams. And it's commendable that this series aims to teach these drugs in the context of their disease setting and the setting in which it's used in the current clinical practice. So for today, we are going to have drugs used in GI cancers, and it will be presented by my friend and colleague, Dr. Shruti Gohel, medical oncologist from Baroda. Shruti, over to you.
Good afternoon. I'm very grateful for this opportunity. I'm grateful to Dr. Vidit Kapoor for mentoring me for this session, and I'm very grateful to Viraj sir and Bhawna ma'am for their guidance. Um, Having a brief overview about the regimens which are used in GI, that is in colorectal cancer and esophagus, gastric and GE junction cancers, we um, we know that the regimens are the main classes of drugs which are used are fluoropyrimidines, platins, texans, anti-EGFR, anti-VEGF, anti-HER2, and immune checkpoint inhibitors. We will try to cover few individual drugs in this session, beginning with oxaliplatin. Um, it was approved in 2002 as iloxantin. It's an alkylating agent, third generation platinum, and it is cell cycle non-specific. The active moiety is DACH. The mechanism of action is formation of intrastrand and interstrand crosslinks, leading to formation of DNA adducts. It's also a radiosensitizer. A question comes up why oxaliplatin is preferred platinum over cis and carbo. The answer is that it has more synergistic activity with fluoropyrimidine and irinotecan as compared to cis and carbo. Also, it has lesser toxicities and it is more cytotoxic due bulky DACH. Talking about its physical properties, it is a colorless aqueous solution of the strength coming in the strength of 5 milligram per ml. Important thing to remember is that it is diluted with 5% dextrose and it should not be diluted with chloride containing solutions like NS or DNS. Also, we have to flush the infusion lines with 5% dextrose before and after giving the solution. It cannot be given concomitantly with alkaline solution like 5-FU. It should also not be used with aluminum containing needles or IV set. It should also not be given with leucovorin in the same bag. However, it can be given concomitantly with leucovorin in separate bags or via Y line. The infusion time is 120 minutes. Uh, if it gets extra visited, we have to remember that warm compressors have to be used. A very common complaint at the time of infusion is vascular pain. It can be reduced by concurrent administration of 5% dextrose. We have to remember certain things about the sequencing, that it has to be given before 5-FU. Also, because of its interaction with irinotecan, it can lead to cholinergic syndrome due to inhibition of acetylcholinesterase, and we have to remember to give prophylactic atropine before giving irinotecan when both of them are given together. Also, the patients have to be advised to avoid cold exposure in terms of touching cold surface or drinking cold beverages. The schedule is 2 weekly schedule. The dose is 85 milligram per meter square, and 3 weekly schedule. The dose is 100 to 130 milligram per meter square. The black box warning is hypersensitivity reactions, including anaphylaxis. So the most common side effect which we face is neurotoxicity. The others are nausea, vomiting, diarrhea, and myelosuppression, of which thrombocytopenia is more common. We also see hepatotoxicity, which is because of sinusoidal injury. Uh, Talking about the special considerations, 1% of patients can develop pharyngolaryngeal dysesthesia following cold exposure. This is not very life-threatening, though the patient might be very uncomfortable. At that time, we have to check the saturation and blood pressure. If everything, the saturation is normal, BP is normal, then we just have to reassure the patient. Anxiolytics are advised. There's no the treatment is not required. However, antihistamines and bronchodilators have been used. Also, we have to remember that in subsequent cycles, the infusion time has to be increased from 2 hours to 6 hours. Talking about peripheral sensory neuropathy, so it can be acute or late. It is the neuropathy is cumulative, dose related, but reversible. So grade 2 neuropathy is seen in almost 10% of patients after 3 cycles and 50% after 10 cycles. Grade 3 neuropathy is seen in 10% after 9 cycles and 50% after cycle. However, it is reversible in 75% of cases, and the recovery begins 3 to 4 months after the discontinuation. This neuropathy is because of injury to small sensory fibers, and it can be treated, managed with gabapentin and duloxetine. Moving to irinotecan, it was approved in 1996 as Camptosar. It's a topoisomerase inhibitor it is a semi-synthetic derivative alkaloid extraction from Campotheca acuminata tree. It is S-phase specific. The 2-weekly schedule, the dose is 180 milligram per meter square. In 3-weekly schedule, the dose is 300 to 350 milligram per meter square. It is contraindicated in patients who have Gilbert syndrome because of higher risk of toxicity. Just like oxaliplatin, it is preferred to dilute in 5% dextrose, and it is given IV over 90 minutes. The black box warnings are diarrhea and myelosuppression. Most commonly, neutropenia is seen. The dose-limiting toxicity is diarrhea. It has two forms, early form and late form. Um, Talking about the special considerations, uh, we know that irinotecan and its active metabolite SN38 are sources of cytochrome P3A4 and UGT-A1A. So their co-administration with their inhibitors or inducers can lead to problems. So if we are using it with inhibitors like bevacizumab or lopinavir ritonavir, it can lead to enhanced toxicity of irinotecan. And if we are using it with inducers of them, like phenytoin or carbamazepine, it can lead to decrease in efficacy of irinotecan. Talking about diarrhea, the early form of it, it is usually seen within 24 hours and it is usually mild in severity. It's a part of cholinergic syndrome where there is increase in secretions like lacrimation, salivation, diaphoresis, flushing. This is dose dependent, and the treatment is atropine. Talking about late onset diarrhea, it is seen, it sets in after more than 24 hours and it can be potentially life threatening because of dehydration and severe electrolyte imbalance. Um, the median time of onset is 5 to 10 days. This is because of abnormal ion transport in the injured intestinal mucosa. It is managed with loperamide. The treatment is that loperamide has to be started at the first poorly formed stool. We have to give loperamide 4 mg stead, followed by 2 mg every 2 hours in the daytime and 4 mg every 4 hours in the night time till the patient is diarrhea free for 12 hours. Moving to fluoro 5-FU, it was approved in 1962 as fluorouracil. It's an anti-metabolite and it is S phase specific. Um, um, Talking about the routes of administration, it can be given IV as well as intraperitoneal, topical, and ocular. Talking about the peculiarities of its infusion, it can be given IV bolus as well as IV infusion. IV infusion can be given in indoor patients via central venous line like chemoport or PICC through infusion pump, because we have to be careful about the rate of infusion. We have to be careful about the infusion rate. It can also be given as an outpatient basis through ambulatory pump. Um, we give it with leucovorin as it enhances the therapeutic effect by increasing the binding of the drug to thymidylate synthetase. This also is preferred to be diluted with 5% dextrose. The schedules are 2 weekly schedule. The bolus doses 400 milligram per meter square, followed by infusion of 2,400 to 3,000 milligram per meter square, given over 46 hours. The 3 weekly schedule is giving 1,000 milligram per meter square IV over 24 hours for 3 consecutive days. The dose-limiting toxicity is myelosuppression. Um, and we also see ascites, diarrhea, hand foot syndrome. So talking about the special considerations, cardiotoxicity is of utmost consideration because in 8% of patients, there can be life-threatening cardiac adverse events. So it is contraindicated in patients who have history of coronary artery disease. The manifestations can be ECG changes, angina, MI, or even acute pulmonary edema. Another special consideration is identifying the patients who have DPD enzyme deficiency, because in them there can be early, severe, and life-threatening toxicities. The toxicities may vary with the schedule. The bolus 5-FU, the most common toxicity seen are stomatitis, mucositis, and myelosuppression. And with infusional 5-FU, the most common toxicity seen are cardiotoxicity. Uh, Talking about what happens if there is an overdose. So if overdose is defined as giving more than 2 times the intended rate, or if more than 50% of the intended dose had already been administered to the patient, which might happen if a patient is there indoor, and if a new nursing staff has come who is not very trained, anything happens. So how do you manage this? So the management is we have to admit the patient for supportive care, and we start GCSF, the baseline blood report, CBC electrolytes, liver function test, as well as baseline ECG has to be done. And we have to continue giving GCSF and other supportive care till the ANC becomes more than 1,000. Um, um, yeah. Moving to capecitabine, it was approved in 1998 as Xeloda. It is an oral precursor of 5-FU. So its mechanism of action is also similar as 5-FU. Also, the consideration of identifying patients having DPD enzyme deficiency is relevant to capecitabine, just like 5-FU. The black box warning is Xeloda, the interaction between Xeloda and warfarin. The most common side effect, which is dose limiting, is diarrhea. The other consideration is hand-foot syndrome or palmar-plantar erythrodysesthesia. Um, so talking about the special considerations, just like 5-FU, even for capecitabine, cardiotoxicity is of concern. It can 3% of patients can develop fatal cardiac toxicities. So again, remembering what was it in 5-FU, it was 8%. So 8% in 5-FU and 3% in capecitabine. So if the patient has prior history of coronary artery disease, even capecitabine is contraindicated in those patients. Talking about diarrhea, just we have to manage it like we manage the chronic form of diarrhea. In irinotecan, we manage it with antidiarrheals like loperamide. There are more chances of hyperbilirubinemia in the patients who have existing liver metastasis. Talking about hand-foot syndrome, we will be discussing it in a bit of detail at a later point of time in this presentation. But we have to remember that this can be prevented by preemptive use of urea diclofenac containing cream. Earlier, pyridoxine vitamin B6 used to be prescribed, but there is current evidence which is suggesting that it is not effective. Also, a very peculiar side effect is loss of fingerprints called dermatoglyphia, which is in the spectrum of hand-foot syndrome. However, this is a reversible side effect, but during treatment, the significance is that the patient might have lost print identification or fingertip scanning technology, which might cause them problem at various places in their routine conduct. Um, Moving to anti-EGFR therapy, talking about cetuximab, it was approved in 2004 as Erbitex. It is G1 phase specific. It is recombinant chimeric IgG1 um, anti-EGFR monoclonal antibody. It is also a radiosensitizer. The loading dose is 400 milligram per meter square, followed by maintenance dose of 250 milligram per meter square given every weekly. Alternate regimen is 500 milligram per meter square given every 2 weeks. The loading dose is given over 120 minutes. If there is no hypersensitivity reaction from the subsequent dose, we can give it over 1 hour. The concerns are infusion-related symptoms, sickness, skin changes like acneiform rash and peroneal inflammation. So talking about acneiform rash, the preemptive approach would help us better. The sites of development of acneiform rash are face, chest, and upper part of the back. Preemptive approach with application of topical corticosteroids and oral doxycycline have shown very good results. Also, the black box warning is regarding cardiopulmonary arrest in 2% of patients. We can see fatal cardiopulmonary complications. Another thing is that we have to have electrolyte monitoring, especially of magnesium, calcium, and potassium. Talking about infusion reaction, 3% of patients can have severe infusion reaction. And if we catch it in earlier grades, if patient develop mild to moderate infusion reaction, from next cycle on, we can re-challenge by giving a slower infusion to the patient with careful monitoring. Also, very important aspect is that RAS mutation, RAF mutation, as well as HER2 mutation are predictive factors for poor response to anti-EGFR therapy. So the patients having RAS mutation, RAF mutation, and HER2 mutation should not be given cetuximab or panitumumab. In terms of combining it with chemotherapy, FOLFIRI backbone is preferred over FOLFOX as seen in Crystal trial. Moving to panitumumab, it was approved in 2006 as Vectibix. It's recombinant fully human IgG2 anti-EGFR monoclonal antibody. So because it is human, it is supposed to have lesser side effects than the chimeric counterpart, that is cetuximab. The dose is the dose is 6 milligram per kg IV given every 2 weeks. The infusion is given over 60 to 90 minutes. The mechanism of action is similar to cetuximab. Most of the side effects are similar to cetuximab. Moving to regorafenib, it was approved in 2012 as Stivarga. It is multiple receptor tyrosine kinase inhibitor. It's KIT, RET, VEGF, PDGFR, FGFR inhibitor. Besides GI, it is also besides colorectal cancer, it's also used in GIST and HCC. The dose is 160 milligram given orally daily for 21 days out of a 28-day cycle. It's given with food. The formulations available are the tablets are in the formulation of 40 mg. And we have to remember to avoid concurrent administration of ketoconazole and rifampicin. The black box warning is related to its hepatotoxicity. Also, just like any anti-VEGF, hypertension is a concern. With this, also the bleeding complications are worrisome in their case. So talking about the special considerations, we have to be careful about the cardiac adverse events. Regarding the hypertension, we have to ensure that the patient has normal BP before starting the treatment. Also, we have to monitor BP every week for first 6 weeks of treatment. However, this hypertension is very easily managed with oral antihypertensives. It can also lead to hand-foot skin reaction, which is a bit different from hand-foot syndrome, which we see with capecitabine. This also we will cover at a later point of time in the presentation. Talking about hemorrhagic events, so we are concerned about bleeding complications in respiratory, GI, gastrointestinal tracts, which can very rarely be fatal too. Moving to trifluridine plus tipiracil combination, it was approved in 2015 as Lonsurf. Trifluridine is a nucleoside metabolic inhibitor and tipiracil is a thymidine phosphorylase inhibitor. So the mechanism of action is that trifluridine is phosphorylated by thymidine kinase and it gets incorporated into DNA where it leads to cytotoxicity. The tipiracil helps in increasing its oral availability by inhibiting its rapid degradation and bypassing the first pass metabolism by thymidine phosphorylase. It is an metabolite. This particular, so trifluridine is not metabolized by DPT. It is metabolized by thymidine phosphorylase. So it is safe to give in the patients who have DPT enzyme deficiency. The two formulations which are available are 15 mg with 6.14 mg and 20 mg with 8.19 mg of respectively of two drugs. The dosage is 35 milligram per meter square per dose of trifluridine component given perorally twice every day with food. It is given from day 1 to day 5 and then from day 8 to day 12 in a 28-day cycle. The black box warning is related to myelosuppression. Most commonly seen is anemia. The other concerns are diarrhea, fatigue, and severe infections. Neutropenia is also seen in 30% of the patients, which can lead to serious infections, and in 1% of patients might also end up into neutropenic sepsis. So this patient have to be monitored carefully, and we can give them GCSF just like we give it for our other chemotherapy drugs. Moving to ramucirumab, it was approved in 2014 as Cyramza. It is human IgG1 monoclonal antibody and it is an anti-VEGF. This particular drug should not be diluted with 5% dextrose. This is what we should remember. Also, we have to give it with a Mira. The infusion has to be given with Mira filter. It is given intravenous. The infusion is given over 60 minutes. And we have to remember that we have to keep the infusion rate to the maximum of only 25 milligram per minute. It should not exceed that. The dose is 8 milligram per kg, given on day 1 and day 15 of every 28-day cycle. Again, the black box warning for this is hemorrhage, and just like any VEGF, the concerns are hypertension. So we have, as we discussed, how we have to manage hypertension in this patient too. We have to have our guards high regarding hemorrhage in any system, particularly GI perforation is of concern, and infusion reactions which can be managed with. So to prevent them, we have to give pre-medications with IV H1 antagonists like diphenhydramine. Proteinuria, just like bevacizumab, is a concern. Effects like RPLS can also be seen. So coming to my last slide, where I have, like, as a recently passed YMO, I have to give my inputs. So I would say that whenever we are reading about the drugs, we should go back to the regimens, and we have to identify this particular important points which will just help us in putting things into perspective. So we have to identify the indications, contraindications, and cautions. We should be knowing what are the drugs in that particular regimen, what are their dosing, then what is the frequency of giving the cycle, what is maximum number of maximum number of cycles for that particular regimen. Also, the sequencing of particular drugs in that regimen is important. We should know the physical properties of individual drug, how they are reconstituted, how they have to be stored when they are in concentrated form and after dilution, and how long can they be stored. Also, regarding administration, we should be knowing the particular pre-medications to be given, the infusion rates. Is there any particular requirement like having central venous line or use the need for Mira filter? Also, we should be knowing how to identify and manage the immediate adverse events like hypersensitivity reactions. For a particular regimen, we should be knowing what is its emetogenic potential and what antiemetic regimen has to be used. What are the chances of neutropenia and whether the GCSF is required in that. Besides that, we should be knowing what are the supportive medicines we should be giving at the time of discharge. We should be knowing what should be the baseline investigations being done and what are the investigations we need in subsequent cycles. We should be knowing the standard limits of various investigations and dose modifications for various toxicities, especially hematological, renal, hepatic, and others. Like here we are taking example of folfoxyri. So what are the dose modifications based on diarrhea, stomatitis, or hand-foot syndrome? We should be knowing what are the most frequent adverse events, what are the most serious adverse events, what are the black box warnings for a particular drug, and what are the special considerations. Like we should, for this particular case, we should be knowing, like we're talking about folfoxyri, so we should be knowing DPD deficiency status. So these are the special consideration which we should be mindful of. So I'm very thankful, and my if one pearl I have to give is that besides other sources which we have like BCCA, EVIC, NHS, I would really recommend reading Clinical Oncology book by Venkat Pradeep Babu sir, and a lot of resources available at ISMPO, YMO, RPO, Google Drive, where there are wonderful notes by students which would be really helpful at the time of exam preparation. Thank you so much.
Thank you, Shruti, for excellent talk. Since you completed the talk way before your time, so we have at least 5 minutes, 5 to 10 minutes for a couple of questions, if somebody wants to post it. And then we will move on to a Viva-like session, which will be done by my guru, Dr. Bhawna Sirohi. She's a medical director at Balco Medical Center, Raipur. And the student who is going to do Viva today is Sachin Gajera. He's a second year student in medical oncology at Vadodara. Hi, ma'am. Good afternoon.
Hi, good afternoon, everyone. And great work, actually. Shruti, I really enjoyed your talk, brushed up everything. And thanks, Viraj, for doing this. And also the Amrita team. Such a great initiative. I mean, we have more than 100 students. It's fantastic.
Yeah. So before we move on, madam, to the Viva, I think so there are good questions mentioned in the Q&A session. Should we take them before we go on?
Yes, I've tried to answer some, or there are more. Okay.
Right, there are more. So one of the questions was very well, and I think so it's a question even for today. We've been using leucovorin only for GI. We don't use leucovorin to modulate the 5-FU in head and neck cancers. And that was the question one student asked. I gave my answer in the chat box, but madam, what is your opinion on that?
So, when I was reviewing the Ayushman regimens, I actually spoke to a few of my colleagues globally as well, and especially, Len Sols, who comes to our MDTs. He has the most experience with leucovorin. I mean, he's been doing it for more than 4 or 5 decades. So he said that, in Ayushman regimens, I suggested, he said, even if you put 50 to 60 per meter square, that's fine. It does help in modulation. So we can go with probably 100 per meter square. We end up giving 400 milligram. There is a global shortage of the use of leucovorin. So what we put in the Ayushman package, what I suggested to the NHA team was 50 to 100 milligrams per meter square, which should be good enough.
Right.
But again, robust evidence regarding that is not there. But again, in GI cancers, we know that it does help.
Yeah, so in GI cancers, there was this study of low dose
Yes.
leucovorin, and even just 10 to 50 milligram per meter square leucovorin was as good as giving higher dose of leucovorin. And like you rightly said, leucovorin is in shortage, so it's a very good use. But my understanding was leucovorin modulates the shorter 5-FU, like the bolus or the
Yes.
short infusion one. When we use the protracted ones, the 48 hours and 72-hour ones, it's a questionable thing whether, because the drug completely behaves differently. The 5-FU behaves completely differently when we use prolong versus bolus. And that's the question comes whether modulating the long part of 5-FU has any role or not. And that has been always my understanding. We have not answered that in part of clinical trial. I skip leucovorin many times, even in colorectal cancer, when I'm not using bolus, but that's just me. So it's an excellent question. A couple of questions we'll take. Would there be any role of EGFR inhibitors like osimertinib in colorectal cancer, since it's an anti-EGFR as well? Anyone would want to take that?
You take that because you do lung as well a little bit.
So, Shruti, want to do, or should I go?
Sir, please tell, sir.
So, the anti-EGFR drugs that we use for GI malignancies are typically the receptor blockers, where we want to block the receptor and the ligand, so the cetuximab and panitumumab, while the TKIs, especially gefitinib, osimertinib, they work intracellularly, right? So, the mechanism of deactivating the MAP kinase is not the same when we use a TKI in colorectal cancer. Vis-a-vis, it is when you have that specific mutation in that EGFR domain, which happens predominantly in lung cancer. So hence, we don't use TKI in colorectal cancer. There have been several questions, but I think so we'll take them later. So, ma'am, we'll start with the Viva of Dr. Sachin. Dr. Sachin, are you there?
Yes, sir. Good afternoon, sir.
So, Bhawna, ma'am, all yours. And then later on, we'll take these questions one by one again.
Okay, so you want me to go through these slides? Okay. Okay, Dr. Sachin.
Yes, good afternoon.
So, what is this rash that you see, which is maculopapular, mainly papular, a little bit pustular as well?
Pustular. Yes, ma'am. It is a acneiform rash for the facial and upper chest region.
Mm-hmm.
Mostly acneiform rash, sir, ma'am.
And what drugs typically cause that?
Anti-EGFR, ma'am. Cetuximab, panitumumab, and TKI also cause this. Lotinib, gefitinib, regorafenib, those drugs, ma'am.
Very good. I think, yes, this is typically what we see with the anti-EGFR. And do you think one anti-EGFR causes more than the other, or both are same?
Both are same, ma'am.
Yes, you're absolutely right. Very good. So what are the grades of toxicity for this rash?
According to body surface area, ma'am, grade 1 include less than 10% of body surface area. Grade 2 include 10 to 30% of BSA. And grade 3 include more than 30% of this body surface area. In grade 4 or life-threatening.
And what are the implications for grade? Why do you want to, so every toxicity in oncology, we want to grade them. What is the implication for that?
If more than grade 2 to grade 3, we can decrease the dose and hold the drug, ma'am.
Yes.
Grade 1 dose we can manage with conservative.
Yes. So as oncologists, I think we have a duty that we must grade the toxicity. You know, whatever toxicity it is, whether it's even tiredness.
Yes, ma'am.
And, you know, grade 1, 2 toxicity, if a patient is tired the whole time, it is not well tolerated. All of you must remember that. So how will you manage this? Because, you know, you will see this quite often because we are using TKIs a lot.
Mostly we advise to emollient and motion before starting of targeted therapy. Just before 1 or 2 days, we avoid sun exposure and apply emollient and moisturizer. After that, we advise to tell patient that wear a loose fitting cloth and as well as apply sunscreen. And advice for doxycycline and ointment, ma'am, gel, clindamycin.
Yeah, and they must avoid sun exposure.
Avoid sun exposure, yes.
Yeah, so I tell all my patients, you know, they should wear a big hat, which is around the head. Yes, I think because face is the one which is very exposed.
Most
and, this is a very distressing rash as well. But what is the implication, clinical implication of developing a rash?
We can say that rash is directly proportional to effect of therapy.
Excellent. Yes. So, I mean, most of the patients who develop a rash do have a good response.
Good response to therapy.
And actually, over time, you keep giving the drug, it actually goes down. And giving antibiotics, I think, as you said, doxycycline is very, very important in these patients. Anything else, Viraj, in this rash that you would like to add? You're muted, sorry.
So yes, this step regimen and this step protocol is very important. We see many a times anti-EGFR being prescribed without giving prophylactic doxycycline, and now we have this randomized study. I think so everybody who uses it, especially panitumumab, which has more skin toxicity as compared to cetuximab, one must use prophylactic doxycycline. I think so that's an important take-home message.
Yeah, I think that's true. Anything else, Dr. Sachin, you want to ask about anti-EGFR? What else should you look for in anti-EGFR when you're giving anti-EGFR to patients? What else should you monitor?
Hypertension, madam. And
that is, I think, anti-VEGF mainly. So the two major class of drugs is anti-VEGF. Anti-VEGF maintain blood pressure, diary, and urine protein. But anti-EGFR, you would monitor for skin rash, of course, but electrolyte imbalances.
Hypocalcium and hypomagnesium, yes.
Yes, I've had a patient who's come to the emergency with convulsions.
Due to hypocalcium.
With severe hypomagnesemia, and you collect, if you miss on the electrolytes, every cycle, I think some of them in the beginning can crash their magnesium, especially because normally we don't do the magnesium levels when but we must do that when we are giving anti-EGFR and cardiac arrhythmias. So, these are the two side effects which are very, very important for your patients. I've just had a patient with a severe bradyarrhythmia which needed pacing. So we were running out of options. So we were thinking whether we should continue anti-EGFR or not. Anyway, we've decided not to. It's a life-threatening complication.
Yes.
So one will be very brave to do that. Okay, so let's move on to the next slide. So what is this condition?
Erythematous rash over palm and discoloration skin over the skin.
Yes.
Hand-foot syndrome, madam. Hand-foot syndrome.
Yes.
Capecitabine over 5 mm.
Okay, you call it hand-foot syndrome or palmoplantar erythema or erythroid. So there's various names that are given to it. So what is the difference between hand-foot syndrome or a hand-foot skin reaction? And how do you differentiate between the two? For everyone, this is very important because the drugs are different as well sometimes.
Edema seen only, madam, in HFSR. Erythema seen in both. Then blister seen in both mostly. Pressure area seen in HFSR and HFS. No pressure area like finger web seen in HFSR. And hyperkeratosis scalus seen in HFSR.
I think very good. The key thing is to be able to identify it. So which drug commonly causes PPE or HFS?
HFS, madam, capecitabine 5-FU, and HFS are TKI mostly, ma'am.
And yeah, it's sunitinib, sorafenib.
And sorafenib.
And recently I had a patient with pazopanib as well, developed quite a severe renal cancer, quite a severe reddening of, palms and soles. So which other chemotherapy drug causes, this kind of reddening of palms and soles, which can be quite painful? Hand-foot syndrome, chemotherapy drug.
Ma'am, doxorubicin, dicyclophosphamide may can.
So cyclophosphamide mainly causes which side effect?
Mostly,
neutropenia is there, but it can cause cystitis.
Hemorrhagic cystitis.
Hemorrhagic cystitis. And doxorubicin, the main side effect that you need to warn patients of is the urine may turn red when they go home.
Yes, ma'am.
And they suddenly come saying that, they've developed hematuria. So it's not hematuria. And emesis is the commonest side effect. So the drug which causes, chemo drug which can cause a really bad hand-foot syndrome are the taxanes. And docetaxel can come with really painful hand-foot syndrome. And we've seen quite bad ones as well. So one must be mindful that, it may be one of these drugs which causes this. I know we don't use it in GI cancers, but we do use it in stomach cancer. Yes. So
yes,
we do use it in GI cancers. Very good. I think this is great. Now, if you had to think about, I'll just ask you a question and then we will talk about an Indian study which was done from Tata Hospital, which Dr. Viraj will take. Tell me, how do you prevent hand-foot syndrome? There are quite a few studies that have been done. Name 3 measures that have been tried to prevent PPE or hand-foot syndrome. One of them is right in front of you, diclofenac. Tell me 2 more.
Really not.
I put you on the spot.
Topical diclofenac use.
Yes, and then the other one is
urea containing
yes,
lotion.
the containing creams, but the pyridoxine.
B6, yes.
Vitamin B6.
We can give in 50 mg BD.
Yes.
Or celecoxib also.
Yes, celecoxib, and also there was 2 studies actually with henna.
Henna.
Mehendi, which is applied weekly. And that was also a small study, but which showed that, it does help with preventing PPE. So these are, 3 things which, which don't cost much, but, we should be aware about it.
Yes,
I don't know about, I haven't used, Dr. Viraj, you've used topical diclofenac. How costly is it?
Yes, madam, we've started using it. There are Indian companies who've started making it. It's very cheap.
Very cheap. Okay. So I recommend henna actually to the women at least. So, but we'll start using diclofenac as well. So are you familiar with this study?
Yes, in fact, after the study, we started using it.
Okay.
Aware of using topical diclofenac, but
Yes.
to the group.
Dr. Sachin, you want to talk about this study? Are you familiar?
Not personally, ma'am. I
Okay.
just know that.
Viraj, you talk about it because you know the study.
Yeah, so it was a DTORCH. Then the investigators named it as DTORCH studies, where you want to use diclofenac as we used to use urea before. So this was diclofenac topical, and it showed the reduction in higher grade 2s and grade 3s significantly, as you can see, 4% in diclofenac versus 1 in 4, 1 in 5, 1 in 6, what you would expect with capecitabine on placebo. And the dose reductions also were reduced significantly because they didn't have to reduce the dose because of this. So 4% versus 14% in placebo group. So absolutely a positive study. And now we have an Indian company. I forgot the name. Lentigena. If some student can remind me the name of the tube, Lenti something, and it's under 200 rupees. So it's very easy nowadays to use this.
Okay, so Dr. Sachin, I'm going to ask you some clinical questions. So what do you see here?
Ma'am, ambulatory infusion pump.
Okay. And I mean, how does it help the patients? Is it
Mainly, ma'am, we use with continuous infusion of 5FU. So it is very easily available, easily helpful for the patient. They can kept in pocket also.
yes,
It
and
goes
they can
with 5 ml per hour.
yes, and they can have treatment as an outpatient. So don't admit your patients for
Yes, ma'am.
infusional chemotherapy.
Yes, ma'am.
You know, a lot of our patients are spending their time in hospitals, so we must try and maintain some normalcy in their life and allow them to continue working while they are
Yes,
having
ma'am.
chemotherapy. So this allows them to do that. Very good. So
Yes.
one of the questions was that, you know, can 5FU infusional be given peripherally? What do you think, Dr. Sachin?
We can give, ma'am, but it can it is an irritant drug, so there is a blackening of vein. So mostly we can avoid.
Yes. So
We
you
can
could,
insert a PICC line or port, ma'am.
yes, yeah, we must. So my preference is a chemo port
Yes,
because PICC line needs weekly flushes.
weekly flushing and
Yeah,
dressing, ma'am.
and chemo port is, you know, under the skin. Patients actually can go swimming with it. They can lead a
Yes, ma'am.
completely normal quality of life. So always prefer a chemo port, and you know, it's a Ayushman patients have access to it as well.
Yes, ma'am.
So it's funded by Ayushman scheme. Very good. Next slide, please. What is the difference between oxaliplatin-induced dysesthesia that you have, which is cold dysesthesia as described, versus hypersensitivity? In a
Mainly,
busy daycare, you need to identify that. This is very important.
yes, ma'am. In pharyngolaryngeal dysesthesia, mainly due to cold exposure of patient, patient is dyspnea, but no bronchospasm, no absence of laryngospasm, no hypoxia, BP is normal or increase. Patient is anxious, so in treatment we can give anxiolytic. Why? Whether in a hypersensitivity reaction, patient is tachypneic, tachycardia seen, dyspnea, bronchospasm is seen, hypoxia with tachycardia or with hypertension. So we give oxygen support, steroid, and bronchodilator. In SOS, we can shift into ICU.
Okay. And what is faster than a anxiolytic? You know, you have a patient in daycare who develops this. So what else can you do?
Lukewarm water, ma'am.
Yes, very good. We
can-
give them a cup of tea or we
Okay.
give them a glass of warm water
Bottom water, yes,
and
ma'am.
we ask them to drink it and it goes away.
Yes,
What
ma'am.
else do you tell patients on oxaliplatin when they go home?
Avoid cold exposure
Very good.
for 2 days and avoid AC and mostly cold exposure.
Yes, and also don't because you know patients will tell you don't put your hand in the fridge.
Yes, ma'am.
So you should tell your nurses that, you know, during the chemo counseling, they must counsel them. Otherwise, you know, they say current lag gaya.
Yes, ma'am.
And so, they should not put their hand in the fridge, not drink cold water and all that. Excellent.
Avoid cold.
Very good. Very good. Next slide.
I have a question there, madam.
Yes.
Can I ask, madam?
Yeah, please. I think this is a very good. Dr. Sachin, you're so well prepared.
Well, Sachin. Sachin, just for the other students, I wanted to know what madam said. Let's say 2 days later, patient puts a hand in the fridge and patient gets a current. Uh, is this neuropathy?
No, sir. Directly, we cannot say it's neuropathy.
Okay.
It's due to oxaliplatin induced sensitivity, sensitivity reaction. Oxaliplatin induced, not neuropathy, sir.
So is this dose limiting? So would you reduce the dose next time?
Yes, sir. We can reduce the dose if more than grade 2 neuropathy is seen.
So you just said this is not neuropathy, right?
In this case, we don't reduce the dose, sir.
Correct. So
we just advise the patient.
These are called cold dysesthesia.
Cold dysesthesia.
Right? For that, you don't reduce
reduce the dose. Yes,
so
sir.
When do you see neuropathy?
Sir, mostly, sir, after 8th cycle. Every 14 days, after 8th cycle, we can say patient says that neuropathy symptoms are starting.
Okay, so does patient complain of neuropathy while on treatment, or typically it happens after you stop treatment?
What, sir? I can't understand, sir.
So let's say you started using Folfox.
Yes, sir.
And 12 Folfox because it was a bad disease.
Yes, sir.
After the 6th dose of Folfox, patient says, I have no neuropathy.
Okay, sir.
Would you continue oxaliplatin?
Yes, sir, we can, sir.
After the 9th Folfox, patient says, I have no neuropathy. Would you continue Folfox?
Yes, sir, we can, sir.
Okay, after the 12th oxaliplatin, patient says, I have no neuropathy. Would you continue Folfox? You see what I'm trying to ask? The oxaliplatin neuropathy typically and almost always happens 1 to 2 months after you stop oxaliplatin.
Okay, sir. Okay.
Hence, it is very important for us to preempt this toxicity because this is more or less permanent, right? Many of us have 4 years, 5 years, 10 years of neuropathy. So you need to stop your oxaliplatin if the data permits. So let's say in low risk, you want to stop at 3 months.
Okay, sir.
Like you said, you want to stop at 4 months. You just don't want to keep pushing it. Otherwise, it will develop. So it's an important message for all students that oxaliplatin neuropathy virtually doesn't come when you are still on the treatment. It happens after you stop it. And once it happens, you can't do anything, right?
Okay, sir. Thank you, sir.
I would like to add one thing. So, in MSK, what they practice is, especially Dr. Leonard, what they practice is that like 12 cycles of Folfox. Even in a high risk patient, what they do is they give like 6 cycles of Folfox, and rest of the 6 cycles they give just 5 of you. So, as a blanket in MSK, it is like if it is like Capox, then 4 cycles of Capox, and rest of the 4 cycles they give only capecitabine. So they don't use 12 cycles of oxaliplatin full doses.
That's right.
So that is a blanket practice.
Same, Dr. Safalta, I do the same as well because
yes, me too. Have started. Yes,
so many trials because this neuropathy is very debilitating. You cure the patients, but then they are left with cotton wool walking and all that symptoms. So I think 6 cycles are enough, or 4 cycles of Capox
should be good enough.
Yes.
So just on oxaliplatin, there was a question, Dr. Sachin, if you can take that. Very interesting question they asked. Cisplatin and carboplatin, we don't use in colorectal cancer. Why is oxaliplatin in colorectal cancer? Can you tell us why? How is it that we do that? Very nice question.
So it's more 50 times higher potent than cisplatin and carboplatin, sir. So
oxaliplatin doesn't work in head and neck cancer.
Yes, sir.
It's not about potency. It is about a component which oxaliplatin
DSC component is in oxaliplatin is there, sir.
Helps them internalize in the intestinal
mucosa. Yes, sir.
So there have been studies for the students who asked this question. There have been studies with cisplatin and carboplatin in colorectal cancer before the discovery of oxaliplatin, and the response rates were merely 5 to 10%. One of the only diseases where platins are not good. I mean, the cisplatin and carboplatin. In oncology, when you don't know anything, you use cisplatin, carboplatin, you would be right. But colorectal cancer is not one of them, right? So very good question.
Oxaliplatin, irinotecan, and carfilzomib, sir. In carboplatin, we can use D5.
Okay. So can carboplatin be used in normal saline?
Yes, sir, we can use.
Yeah. Same for irinotecan as well, because, you know, I think this implication, oxali you cannot use, but the
Yes,
rest you possibly can, irinotecan as well. But I think it has a huge implication for our patients with diabetes. So, you know, you want to avoid 5% dextrose with those patients. So then I think I'll just ask you a few more questions just for education. How do you prevent early onset diarrhea with irinotecan?
We can give ma'am injectable atropine.
Very good.
Sub-Q or IV.
Yes, yes. I think this is something, you know, which should not be missed from the protocols that we do. And any questions you have?
No.
Okay, great. Any other questions from the audience? And one more question, do you routinely do DPD testing?
No, ma'am.
For 5FU? I mean, I don't do it
No.
because it's expensive and it takes about 7 to 10 days to come back, but I do it in elderly patients. And the reason being, you know, the reserve is quite less in elderly patients. If they have grade 4 neutropenia, they may not recover from it. So all my patients above 70 years of age, if I'm planning FOLFOX, I would plan for doing a DPD testing because, you know, waiting for another week is not going to harm or whatever. And I don't know, Viraj, what your practice is for DPD testing.
Correct. So I have not started doing it for all, but like you said, elderly, where you are,
Yes.
you definitely go with that. Just on the DPD, there was a good question on the chat box. Can we use S1 if patients have DPD?
Yes, sir.
Oh, yes. I mean, we published with, I think you can look it up. We published 3 case reports with Sameer Rastogi is the first author. We published 3 case reports from Tata Hospital where they had this DP. I mean, they all 3 were admitted with, I think, grade 4 diarrhea and neutropenia and young patients. And we then used, actually, in those patients, we used Tegafuricil. But I think S1 also can be used as well in those patients.
Yes. And good question again. Let's say patient develops in DPD, patient develops a lot of diarrhea. Can you use octreotide? That is the question. One of the students is asking, Sachin.
Sir, mainly in 5FU based toxicity, we can use uridine triacetate. This is an antidote. We can use octreotide.
Have you seen DPD diarrhea before?
No, no, sir.
You'll never forget, ever. Ever you will forget. So yes, we have used the octreotide, we have used morphine just to save the patient. It's 30, 40 diarrheas and it's almost always ends up in ICU. So yes, it has been, we must use all this. If God forbid you give 5FU to DPD, then you'll have a good big day in the wards.
Then there's another question, Dr. Sachin. Can we use adjuvant irinotecan plus capecitabine in a patient with severe neuropathy? I think this is a good question. You need to know the trials as well here.
Capri, we can use, ma'am, but I don't know perfectly.
No, you can't actually. All the trials with irinotecan were negative for adjuvant. So, you know, the trials with adjuvant cetuximab, bevacizumab, irinotecan were all negative. And if you come to our molecular MDTs, you'll see we keep on debating in pseudo-adjuvant setting, should we use targeted irinotecan? And the answer is always no. because the adjuvant trials with these drugs were actually negative. Means some of them were, I think the irinotecan arm did worse than the other arm. And I think we can do another session on this, on the treatment bit. So we can't use it. Folfox or 5-FU or capecitabine remains the standard for adjuvant.
Okay.
And then, so why wasn't irinotecan not successful in adjuvant but useful in metastatic? You want to take that, Viraj, or Dr. Sachin? You try that first. So I think let Viraj handle this.
So the reason we don't know, so the PETAC study, everybody thought it's going to be a positive study.
Yeah.
But it missed it. And then there were a couple of other studies to see whether it was a spurious result or not. But all three studies studying adjuvant irinotecan in colorectal cancer did not do well. In fact, even after in metastatic colorectal cancer, after your resection, adjuvant irinotecan doesn't work. So we have now plethora of evidence to say that once there is no clinically evident disease on radiology, giving irinotecan to these patients for colorectal cancer doesn't make sense. The reason I don't know, but we have enough evidence to conclusively say that no irinotecan. Good question.
And the key thing to remember is something that works in advanced setting may not work in early setting. So one has to do the trials to prove that it's going to work in early cancers. So I think we are going on to treatment now. If the ctDNA is positive after 3 months of Folfox in adjuvant setting, can we switch to Folfiri? No, absolutely not. So I think you should not be doing ctDNA also. So I think that could be another liquid biopsy. We could do a whole session on liquid biopsy in cancers generally. Okay. Anything else? Viraj, do you have any questions? Dr. Sachin, you are very good. Thank you.
Thank you. Thank you.
Substitute S1. So I'm just reading the questions. Please tell us S1, TAS102, and UFT combination. So initially we had UFT, tegafururacil. It's a different version of capecitabine. Again, same fluoropyrimidine pathway. And then S1 uses this tegafururacil and then adds otoracil and gimercil to prevent diarrhea. So that's S1 for you. And TAS102 is completely different fluoropyrimidine. So in a way, they're all fluoropyrimidines, but their molecules are different. Their toxicities hence are a little bit different. So TAS102 has less of diarrhea, but more of neutropenia. S1 has a lot of diarrhea, but no hand-foot syndrome, no cardiac problem, like that, so on and so forth. Maximum cycles. So nobody's asking about anti-angiogenics. That's strange. So,
yeah.
Sachin, what about bevacizumab and ramucirumab in colorectal cancer? When do you use bevacizumab?
Sir, in left-sided colon cancer with KRAS and NRAS wild, we use bevacizumab, sir.
The other way around?
What, sir?
Is the other way around? You meant the other way around? You answered completely the opposite.
Right side, sir. Right side.
Okay, so you can use left-sided all RAS wild type, but that's where anti-GFR is preferred, right?
Okay, sir.
So left-sided, all wild type, RAS wild type, BRAF wild type, we typically tend to use anti-GFR. Rest all cases, we want to use bevacizumab. Can you use bevacizumab in adjuvant setting?
In GI, sir, after Not sir, sure, not sir. In recurrent metastasis, we can use.
Correct. So no bevacizumab for adjuvant. Okay. I don't know any disease in the body where we use adjuvant bevacizumab. So
Sir,
no.
ovary, sir, adjuvant we can use.
Again, that's a questionable thing. So the benefit was, as per the ICON study, the benefit was only for stage 4, or the CRS was in question, right? Because
Okay, sir.
the mechanism of action is, if you don't have any disease, what anti-angiogenesis you are going to target, right? So hence that's how we remembered in exams that bevacizumab in adjuvant setting is a big no.
Okay, sir.
Ovary also, there was a question mark on that. So real world experience on regorafenib, yes, it's a very toxic drug to be used. Remember the drug dose which was started to be advocated was 160 milligram, that is 4 pills a day. I don't know any investigator, any doctor uses 4 pills to start off with. We just start with 2 pills, and in fact, in some patients, we have to start with 1 pill. Even 40 milligram patient starts getting HFSR, mouth ulcers, and slowly you gradually go up to 80. And 80 is the dose you stop. You don't need to go up. Okay, we have now studies to say 8 is good enough in stomach cancer as well as in colorectal cancer. So that's the real experience. We use regorafenib, but you stop at 80. Okay. Can bevacizumab use post-metastatectomy? No. So in an adjuvant setting, we discussed this. No. We'll use that. So which one, madam? It's a question. Which one we will use, anti-EGFR or anti-VEGF, when we are treating stage 4 colorectal cancer with liver metastasis? Again, assuming we are talking about all RAS wild type, all BRAF wild type.
So I think, so my preference is a modified FOLFIRINOX with bevacizumab.
Based on Cairo 5?
Based on Cairo 5, and also because there were a lot of loopholes in the trials with anti-EGFR. But yes, you can also use FOLFIRI plus either cetuximab or panitumab as well.
Excellent. Yeah, so that's what I do. Left-sided, I do doublet plus anti-EGFR. Right-sided, I do Cairo 5, triplet plus bevacizumab. Right. Does capecitabine interact with proton pump inhibitors? It's a good question. Yes.
Yes, sir. Yes, sir.
So we typically don't like to use pantoprazole or esomeprazole with capecitabine. We use ranitidine if at all we have to use.
Can I
So
add
other
one
drug
thing?
interacts with Dr. Sachin with capecitabine commonly that we should not be adding. Allopurinol, actually.
Okay, ma'am.
PPIs are the other one that we should avoid. I
I
think
want
Dr.
to add,
Shruti or
yes, I wanted to add something about the response. So actually in the study, when the cetuximab and bevacizumab were compared, and it was in the conclusion, it was shown that cetuximab patients were on the cetuximab, they had done well. The response was well. But actually what happened is that uh, in the cetuximab arm, 42 patients, they discontinued treatment because of side effects. And here in the bevacizumab arm, it was 24 patients who discontinued. So finally, the number of patients who were on cetuximab, they were less, and then the percentage was higher. So that's how they came up with the study. But actually, when you go through it, you will find that it is not so. So it is even if you go ahead with the bevacizumab, then also you will be having almost the same response as that of the cetuximab. So this is one caveat which is there, and like MSK, Dr. Leonard, he never gives, even for the response, he does not give cetuximab for the response. It is like he prefers bevacizumab in first line and second line, and then go ahead with the cetuximab and panitumab whenever it is. Yes. But it is a common concept we in all the conferences we have heard that cetuximab is a better responder. So when you want to have better response, when you go for resection, you want to go for resection and you want a response, then you go ahead with the cetuximab. Rather than that, if you have to add something else, then folfirinox is a better drug, folfoxary plus, and then if you want to add, you can add bevacizumab.
I think that's a good point. My preference, because mainly for cost reasons, is folfoxary bev. With the generics available and everything, even if you have to use the biosimilar cetuximab, this turns out to be more cost effective. And I think the only patient I had a PATH-CR liver met had folfoxary plus bev, a young girl. So, but I agree, you can use anti-EGFR as well. And I think the reason Len doesn't recommend anti-EGFR right at the beginning is mainly because of the skin toxicity.
Yeah.
Is, to socially, it becomes a big challenge for our patients to go out, and lead a normal life. And I mean, I kind of endorse that as well, that, it's a very horrible drug, actually, especially with the face acne and everything. Some patients have it really bad.
True. Yeah, so young woman getting a stage 4 colon, very difficult to use anti-EGFR.
Yeah.
Even if they're doing well, they'll not continue. Okay. So I think we did well.
Yeah.
We answered most questions. Shruti, you want to have a final word before we hand it over to organizers?
So we got very good insights from Madam and you, sir. Really, like we could get the pearls from this, which is very important from the practice perspective too. So I'm very grateful to Bhawna Madam and you for sparing your time. I'm also grateful to Safalta Madam for her insights. And it had been a boost to all of us YMOs that all the stalwarts like you took out time to give us guidance. Thank you so much to all of you. Thank you so much.
Thank you, Shruti. Thank you, Bhawna ma'am. It was a good session.
Thank you. I just want to say that, we'll have the molecular MDT this week at 5 p.m. And Dr. Amol Akhade will first 10 minutes present the practice changing stuff from GI ASCO. Because we had some fantastic stuff at GI ASCO. So the first 10 minutes will be dedicated to that. And of course, I already have 7 or 8 very challenging cases that we'll discuss on Friday. Great. Thank you. Thank you so much for this.
Thank you, everyone. Thank you, everyone.
Thank you.
So
Thank you,
before
everyone.
ending, I would just like to say that our next session will be on drugs used in head and neck and CNS malignancies. Our mentor will be Dr. Akhil Kapoor, sir, who is the professor of medical oncology at Tata Medical Center, Varanasi. Our moderator will be Dr. Venkata Pradeep Babu Koela, who is the CEO, Shankara Cancer and Research Institute, Tejpur. Our examiner will be Professor Vijay Patil, sir, who is a senior consultant medical oncologist attached to PD Hinduja Hospitals. And our speaker will be Dr. Supreet RN, who is a consultant medical oncologist at Sri Shankara Cancer Hospital, Bangalore. So before ending, I would like to say that for every session, we will be having an examinee like we had Dr. Sachin today, so who has agreed to participate in this mock viva for the benefit of all his fellow students. So I would encourage all the DM and DRNB students to please volunteer to participate for this mock viva, because it will not only give you an exposure, but it will you will also be preparing and reading up and getting your doubts clarified, and also it will be a great opportunity to directly interact with the senior faculty members across the country. So those who wish to volunteer as examinee, please contact me. So I have nothing more to say. I want to thank once again Dr. Bhavna Sirohi ma'am, Dr. Sapalta Bagmar ma'am, Dr. Viraj Lavingia sir, Dr. Shruti, and Dr. Vidit Kapoor sir, and of course Dr. Sachin. Yes.
Thank you so much.
Thank you. Thank you, sir.
Really
Thank you,
welcome.
ma'am.